Welcome back. This is Dr. Gary Badger talking to you about pediatric sedation and anesthesia for the children. And this is the fourth module that we'll begin to discuss some topics of interest to you. I receive no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. At any time while viewing the video streaming course, you can take a break by simply pausing your computer. At the completion of this section, you will be asked to take a short exam in order to complete the requirements for streaming video courses. At the time, you will receive instructions regarding taking the exam. Section Overview. This section presents information to create an understanding of the continuum of sedation through which the dentist can make appropriate choices of pharmacologic agents that can be safely and effectively used for the various pediatric dental sedation procedures. This course is part of a 16-hour comprehensive program designed to meet the requirements of Texas State Board of Dental Examiners Rules 110.17, Sedation Anesthesia of Pediatric Patients. Today we'll be talking about Module 4, Pediatric Respiratory Assessment, including airway anatomy, physiology, and management. The images being used in this presentation are taken from non-copyrighted sources in electronic media and attributed as possible. The de-identified images are provided as an educational resource to illustrate techniques and procedures for clarity. The objectives of today's module are the participant should be able to assess airways by anatomical evaluation, understand airway physiology, and understand how to manage airways. Airway anatomy compared to adults. The child's head, the head of pediatric patient, is larger relative to body size with a prominent occiput. This causes the neck to flex, lowering the chin to the chest, and predisposes the child to airway obstruction. For sedation, anesthesia, this can be resolved by using a shoulder roll or placing a folded towel under the patient. This makes laryngoscopy more difficult to align axes of oral, laryngeal, and tracheal. Airway anatomy. The tongue is relatively larger and the mandible shorter in the young child. Adenoids and tonsils enlargement is found in preschool children. As we know, as children grow, they tend to be exposed to upper respiratory infections, and very frequently we see patients present to our office with enlarged tonsils. It's very important to understand that this is a compromise in the airway anatomy. As we've said that the tongue is larger and the mandible shorter, this compresses the pharynx and does not allow a great deal of room for the airway anatomy to align itself. The result of this enlargement of the tonsils and adenoids results in a loss of airway space, which may limit mask ventilation, obstruction, and laryngoscopy access. Sedation anesthesia drugs cause loss of muscular tone and a potential upper airway obstruction. It does this by causing the soft tissue, the muscle tone, to relax, and so the soft tissue sags, and as it sags, it can oppress the positioning of an airway that is satisfactory for good ventilation. The loss of airway space is limited by the size of tonsils and adenoids, but also by the soft tissue which is not anchored to bony or cartilaginous structures. This occurs in the pharynx, and it is thought with recent science that those loose airways collapse when the muscle tension decreases or when drugs which override the muscular tension cause the effect of decreasing and relaxing muscles. Airway anatomy. The hypopharynx is relatively shorter in height and narrower in width than the adults, which is more elliptical in shape. This hinders supraglottic airway placement. As we look at this, the total height, if you will, as the patient is sitting up in the chair from the base of the tongue until the beginning of the trachea, is a very shortened area until full development occurs about the age of 8, when the lungs mature and the size of the tracheal tree is enlarged. The larynx is relatively higher in the neck at C4 to 5, whereas in the adults it's at C6. Because of this high position of the larynx and access to the glottis, it allows the larynx to be accessed by displacing the tongue laterally, as you use the laryngoscope to displace the tongue laterally and visually look directly at the opening of the glottis. When it's higher in the neck, it means that additional elevation of the chin is necessary to be able to access clearly where the opening to the glottis is. The vocal cords are angled from anterior inferior to posterior superior. Let me say that again. It are angled from the anterior inferior portion of the larynx to the posterior superior position, making tube insertion challenging or traumatic. Often traumatic because the edge of the glottis may get caught in the pointed area of the endotracheal tube and can cause some scratching or irritation, and it's very difficult to align properly. The epiglottis in children is more U-shaped and lies across the glottic opening. The Miller blade of the laryngoscope is prepared by some anesthesiologists, which directly lifts the epiglottis out of view, and it allows ready access to the glottis and the opening for endotracheal tube intubation insertion. The cartilaginous portions of the airway are soft and compliant and do not calcify until teenage years, accounting for the obstructive nature of the soft tissue with negative pressure. Evaluation of the airway indicates that anesthesia given to children with upper respiratory infections causes an increase in risk in perioperative respiratory complications such as airway obstruction, post-extubation croup, pulmonary atelectasis, etc., and also exposes the medical caregivers and other hospitalized children to viral pathogens. Respiratory infections causes an increase in the inflammatory elements in the glottal area, and it causes the tissues to be compromised in size, thereby restricting the size of the endoscopic tube, the endotracheal tube, to be inserted. And if this should occur, then selecting a half size smaller may be the answer to this critical condition. Pulmonary atelectasis is the complete or partial collapse of the entire lung or the area lobe of the lung. It occurs when the tiny air sacs, the alveoli, within the lung become deflated or possibly filled with alveolar fluid. Atelectasis is one of the most common breathing respiratory complications after surgery. Atelectasis can make breathing difficult, particularly if you already have lung disease. General anesthesia is a common cause of atelectasis. It changes your regular pattern of breathing and affects the exchange of lung gases, which can cause the air sacs and alveoli to deflate. In addition, the traumatic insertion of the endotracheal tube may cause some inflammation in the glottis, and as a result, swell and decrease the size of endotracheal tube we wish to place. Advice from the Braslow tape: for selecting size, it would not be applicable in this condition because the infection has caused a decrease in the size of the alveolar tracheal position. Obstructive atelectasis may be caused by a mucus plug. A mucus plug is a buildup of mucus in your airways. It commonly occurs during and after surgery, because you can't cough and the mucus builds up. So as the patient recovers and the mucus is coughed up, this obstructive atelectasis has caused some reduction in the sacs that are necessary for ventilation. Drugs given during surgery make you breathe less deeply, so normal secretions collect in the airway. Croup. Croup is caused by an infection. There are two types of this condition, viral and spasmodic. The virus that is most often causes croups is parainfluenza. The child may make high-pitched wheezing sounds in his lower airway when he breathes in. The croup sound in the upper airway is a harsh, loud sound known as stridor. And upon inspiration, this crowing type of noise should be an alert to the clinician that some treatment is necessary to reduce the inflammation from the infection. Spasmodic croup comes on suddenly, often in the middle of the night. Your child might wake up gasping for air. He might also be hoarse, have stridor, and a barking cough. To treat, use a cool mist humidifier to moisten dry air. If it's cool outside, open a door or window for a few minutes. Fresh, cool air may calm the symptoms. Croup, in terms of its impact on sedation, is that inflammation may be apparent in the bronchial tree, and as a result, a reduction in the size of the endoscopic endotracheal tube results. Airway evaluation. Children with severe developmental delay often have several coexisting diseases. Most often, GERD or gastroesophageal reflux disease and chronic lung disease, which must be premedicated and anesthetized as appropriate for these conditions. Seizure disorders, anticonvulsant levels, should be documented on the present dosing regimen in the past 6 months. As the patient appears for sedation, it needs to be updated to ensure that the patient has been taking, if they had some recent convulsant activity, patient should be taking the valproic acid, Depakote or Depakane, and should have LFTs documented within 6 months. Anticonvulsions should not be withheld the day of surgery. LFTs are liver function tests. Liver function tests were carried out in this study of 206 adults and children taking anticonvulsants to determine the prevalence of biochemical abnormalities in asymptomatic patients. It was observed that serum gamma-glutamyl transpeptidase was elevated in 74.6% of patients, alkaline phosphatase in 29.7%, alanine aminotransferase in 25.2% of cases, probably reflecting hepatic enzyme induction by the use of anticonvulsants. Trisomy 21. Children with Down syndrome have macroglossia, a narrowed cricoid cartilage, and a greater frequency of postoperative airway obstruction and croup. A history of sleep apnea should be sought. Children with trisomy 21 are often resistant to sedative premedications. They are also susceptible to atlantoaxial subluxation with neck flexion and may be at risk for spinal cord injury. The narrowed portion of the cricoid cartilage in children is a natural occurring anatomy of those teeth, and until the patient matures and the narrowed position opens up to a greater degree, the airway obstruction by a croup becomes a consistent risk factor. So they are also susceptible to atlantoaxial subluxation, and this subluxation may also change associated with growth. Airway assessment for cleft lip and palate children generally have no special handling needs prior to or on induction. Often, cleft lip and palate children who are being sedated have oral intubations rather than nasal intubations as which occurs on pediatric patients who are healthy. Congenital heart defects, if you have a cardiologist define the nature of the defect and its effect on the airway through a consultation, finding out what concerns they might have, determine a baseline O2 saturation, blood pressure in both arms. Children with pacemakers should have an ECG to determine the cardiac rhythm. The airway assessment for children who have cardiac congenital heart effects is really important to work closely with a pediatric cardiologist to ensure that the risk of sedations for these children will be effective and appropriate based upon the nature of the defect and the effect it has on the airway and the oxygen saturation. Airway assessment for children with diabetes should be operated upon as first cases in the morning. Determine the insulin regimen and the degree of outpatient control. For minor outpatient surgery, half the total morning dose of insulin should be given subcutaneously as regular insulin after starting an IV on the morning of surgery. The IV should be a dextrose-containing solution, typically D5 lactated ringers. Serum glucose should be monitored hourly thereafter in a sliding scale used to redose subcutaneous insulin values. Air physiology, oxygen consumption of an infant is relatively greater than adults, 6 milliliters per kilogram per minute versus 3 milliliters per kilogram per minute for adults. Combine the consumption with a lower functional residual capacity, and during apneic intubation, rapid desaturation can occur. And because that might occur, it's really important to provide some oxygen to a high degree to the patient prior to the intubation attempt. Carbon dioxide production is increased 100 to 150 milliliters per kilogram per minute compared to 6 milliliters per kilogram per minute for adults. So the CO2 produced is nearly twice as much as accommodated by the adults. The respiratory rate in children is higher to rid the CO2. The respiratory center can be stimulated by neural impulses generated in the peripheral chemoreceptors of the aortic and carotid bodies. Opioids primarily depress the central chemosensitive area, that is hypercapnic drive, while inhalation anesthetics and benzodiazepines exert greater influence on the chemoreceptors in the carotid and aortic bodies, that is the hypoxic drive. At high doses, all classes can depress both of these mechanisms. The respiratory center, located centrally in the brain, occurs in the pontine and the medullary area of the brain, and it's very sensitive to the increases on pH, which are the escaping hydrogen ions when dissociated with bicarbonate existing or coming from the exhalation of the patient, the carbon dioxide. When this happens, the central chemoreceptive areas become responsive and exert the respiratory system to increase the rate, although it is modulated by the neural impulses of the peripheral chemoreceptors who are more sensitive to the hemoglobin, oxygen, and carbon dioxide values that pass through these areas. This is an example of what the pediatric air assessment anatomy of the system is. There is the nasal cavity, the pharynx, which of course is very short, larynx was even shorter, and the respiratory tract from the trachea down to the primary bronchi and into the lungs. You can see that this tract in this particular model is very tall and slender, and it allows the adults to have increased opportunity for good oxygen saturation. For adults, the distance between the larynx and the trachea is much shorter, and as a result, it limits the amount of residual oxygen that remains, and so it provides a much lesser oxygen residual volume in the lungs when expiration has occurred. Therefore, the respiratory rate in children is much greater to fill these spaces and allow sufficient oxygen to reach the lungs. A good history is important to determine a potentially difficult airway, such as complications at birth. Premature children have the opportunity to have some difficulties with airway development, or prior trauma to the airway, or surgery to the airway, or prior anesthetic complications. Discussing this with the parent and the birth opportunities when they occur allows us to have an adequate history so we can assess the potential for those difficult airways. The complications at birth could be related to the airway not being fully developed, or prior trauma from that area of anatomy, or surgery to the airway for one reason or another to produce a system that may not be as smooth as necessary and result in some turbulent flow of the gases. A current symptom history of URI, or difficulty speaking, breathing, feeding, hoarseness, and noisy breathing can also determine difficult airways. And listening to the exchange of air when you auscultate the tracheal area, you will be able to hear the differences between laminar flow of the gas versus the turbulent gas flow. And as a result, it will mean that there is something that's going on that's disturbing the normal airway exchange. Is there a history of snoring? Daytime drowsiness or stopped breathing during sleep may help identify obstructive sleep apnea. Is there a limited head extension, reduced mandibular space, and increased tongue thickness? Is this a result of neck fusion? One study by Uzono et al. From pediatric anesthesia showed a 42% incidence of difficult laryngoscopy where bilateral microtia was associated. So when there's something wrong about the ears, it increases the incidence of difficult laryngoscopy. And that could mean a concomitant area of development malformation resulting in the more difficult airways. This is a comparison of the differences in airway in child versus adult. What we see here is, relatively speaking, the tongue is larger in proportion to the mouth. The epiglottis tends to be more U-shaped in the child and shorter in the adult. Vocal cords have an upward slant going from anterior inferior to posterior superior in the child compared to the horizontal position of the vocal cords, the glottis, in adults. This means that during the process of doing endoscopic insertion, that the upward slanted vocal cords of the child is more difficult to reach, and because it's more anteriorly located, it is difficult to uncover so that direct observation of your intubation attempt is made. The larynx tends to be more anterior and superior in the child compared to the child, and the narrowest part of the child's airway is at the level of the cricoid cartilage. The trachea is narrow and less rigid in the child, and the lungs have less capacity in the child and therefore less functional airway reserve. Here's a diagram on the right-hand side which shows the anatomy of the laryngeal area. We can see on the left-hand side is the adult cartilage. And the adult cartilage is very straight, going from top to bottom, whereas the child's cartilage on the right-hand side tends to be funnel-shaped, and as it reaches the point of the cricoid cartilage, becomes very narrow. In fact, it becomes the narrowest part of the trachea, and is very difficult to insert endotracheal tubes in that particular area because it crimps down so quickly, and it may mean the reduction of the size of the endotracheal tube than what we originally thought. The funnel shape of the child patient results in the narrowing of the airway inferiorly compared to an adult. The physiology of airway is that during normal inspiration, negative interpleural pressure gradient generated in the thorax creates a pressure gradient from the mouth to the airways, resulting in airflow into the lungs. Extrathoracic airway caliber decreases during inhalation, whereas intrathoracic airway diameter tends to increase. Under normal conditions, change in airway caliber during respiration is clinically insignificant. We know that the intercostal muscles, the exterior, cause an expansion of the lung field and a contraction with the interior intercostal muscles. And therefore, this process is the process by which negative pressures occur and draw air into the lungs, and during expiration, the expansion of the contractions has concluded, and the contraction of the airway chest, intercostal muscles, results in the expiration of the carbon dioxide. However, significant narrowing of the upper airway increases airway resistance, and a higher pressure gradient across the airway is required if minute ventilation is to be maintained. In other words, if we want to maintain the same level and volume of oxygen coming across, we need a greater pressure to force it through the narrowed airway. A greater pressure gradient generated across the airway accentuates the normal respiratory and expiratory effects on the airway. Consequently, the greater the negative pressure generated in the pharynx during inspiration tends to result in further collapse of the upper airway. Remember that scientific evidence has shown that it's unlikely to be the tongue dropping back into the pharynx, but it seems to be the negative pressure on the soft tissue in the unsupported areas of the airway results in the obstruction. Airway developmental characteristics. In summary, the pediatric airway is smaller in diameter and shorter in length than the adults. The young child's tongue is relatively larger in the oropharynx than the adults. The larynx in infants and young children is located more anteriorly compared with the adults. The epiglottis in infants and young children is relatively long, floppy, and narrow, and tends to cover the entrance to the esophagus. In children younger than 10 years of age, the narrowest portion of the airway is below the glottis at the level of the cricoid cartilage. During normal inspiration, negative intrapleural pressure generated in the thorax creates a pressure gradient from the mouth to the airways, resulting in airway into the lungs as explained. Extrathoracic airway caliber decreases during inhalation, whereas intrathoracic airway diameter tends to increase. Under normal conditions, changes in the airway caliber during respirations are clinically insignificant. We do know, as a repeat of this message, that the inspiration and expiration is controlled by the contraction of the internal, and external muscles. However, significant narrowing of the upper airway increases airway resistance, and a higher pressure gradient across the airway is required if minute ventilation is to be maintained. A greater pressure gradient generated across the airway accentuates the normal inspiratory and expiratory effects of the airway. Consequently, the greater negative pressure generated in the pharynx during inspiration tends to further collapse the upper airway. Airway physiology. Differences in anatomy of the child versus the adult. A prominent occiput in sleeping child causes flexion of the neck, allowing the tongue to obstruct the airway in a shorter neck. This can be alleviated by placing a shoulder roll under the patient. Resistance across the airway under laminar flow conditions is directly related to the length of the tube and the viscosity of the gas, and indirectly related to the fourth power of the radius. Thus, airway resistance is primarily influenced by the diameter of the airway. In addition, the relationship between the pressure gradient across the airway and the subsequent flow rate generated is influenced greatly by the nature of the flow, that is, laminar versus turbulent. Laminar flow is inaudible and streamlined, typically through straight, unbranching tubes. The flow rate under laminar flow conditions is directly related to the pressure gradient or the driving pressure. Conversely, turbulent flow is audible and disorganized through branched or irregular tubes. Turbulent flow, for example stridor, tends to occur with high flow rates and often under conditions of airway narrowing and a high resistance. A greater pressure gradient is required to move air through a tube under turbulent flowing conditions. What we are saying here is that as long as the child remains calm and relaxed, then laminar flow is present. If listening to the lungs to hear great exchange, laminar flow is inaudible. While we have the pretracheal stethoscope that's in position, if we had pressure and turbulent flow, then that would be audible and disorganized. Therefore, determining if your patient is under stress and trying to breathe faster and hotter and maybe working harder, then this results in turbulent flow, and this would be something that we would hear in our stethoscope compared to the laminar diameter. Neuromuscular control of the upper airway is controlled by cranial nerves 9 and 10 and is inhibited to a greater degree than diaphragmatic activity from the phrenic nerve during sedation and anesthesia. Thus, the negative inspiratory pressures that develop with diaphragmatic contraction may reduce the diameter of the pharynx, a collapsible segment between two relatively supported structures, the nasal passage and the trachea. These areas are responsible for providing an obstruction because of the collapsible segment. These areas typically involve narrowing of the anterior-posterior difference between the posterior pharynx and the soft palate, epiglottis, and to a lesser degree, the base of the tongue. Consequently, the pharyngeal segment functions as a Starling resistor, a collapsible tube whose caliber is influenced by pressures within the lumen of the airway and soft tissues. Here's an image and illustration of the management of asthma, and this demonstrates inflammatory elements within the tracheal tubes and the relaxed smooth muscle that goes on in a wall that's inflamed. So the middle picture shows us a tube that has some internal inflammation occurring as a result of the asthma and irritation, and in addition, the far right image shows us not only is the wall inflamed, but the tightened smooth muscle decreases the lumen by an exponential amount. The air is trapped in the alveoli and cannot successfully be removed. Under the condition where the bronchioles become narrowed, as in the asthmatic condition above, or crying, turbulent flow occurs and resistance to airflow increases exponentially. So with laminar flow, with the irritation to the internal structure of the tracheal tube and the inflammatory elements and the tightening of the muscles, the lumen is decreased exponentially rather than linearly. Airway management that has bronchiolitis. Bronchiolitis is a very common early affection of the bronchial tree. The image you see on the left has a smooth muscle, the bronchial tube, and the alveoli, and the normal diameter of the airway. On the right-hand side, we have a bronchial tube during bronchiolitis. Bronchiolitis is caused by some irritation and infection, and it results in inflammation narrowing the tube and making it much more difficult for airway to be exchanged. In addition, the tightening with a smooth muscle around the bronchioles decreases the size of the tubules delivering air to the alveolar sacs, and the alveolar sacs then are facing trapped air which doesn't have an opportunity to decrease. So the airway is very difficult to get into the patient's lungs and gives them a very anxious feeling not being able to breathe under bronchiolitis. Bronchiolitis is a patient with having difficulty to distinguish from asthma. Perform a trial of nebulized epinephrine or albuterol, and if no improvement, then consider oxygen and suction of the airway. That is, bronchiolitis as an infection and it's difficult to distinguish from asthma. So give some nebulized epinephrine, which is for the bronchiolitis, or albuterol, and if no improvement, then consider oxygen and suction of the airway, which should reduce the amount of inflammation, and the nebulized epinephrine will reduce the impact in bronchiolitis. Management of the airway. Properly performed mask ventilation is the fundamental rescue technique for overdosed sedation patients. Let me repeat this. Properly performed mask ventilation is the fundamental rescue technique for overdosed sedation patients. We know from studies discussing rescue for patients who are hypoventilating is that compared to being within the hospital using a bag valve mask, it's as effective as being endotracheally tubed. So if you're having difficulty with your ventilations, make sure you have an adequate seal that allows chest rise to occur, and continue to do CPR air rescues with the bag valve mask device so that it allows you to ventilate the patients appropriately until EMS arrives. Remember that if you're doing this alone, the rescue ventilations, one breath for every 3 seconds, and once that occurs, you are doing rescue breaths. If, however, you are trying to do compressions at the same time you are doing the breathing, the compressions are 30 to 2 breaths. So 30 chest compressions, once those are done, 2 rescue breaths, and then back to your resumption of the CPR. Again, 30 to 2 when you have a child who is non-responsive. The head tilt, chin lift, jaw thrust, and continuous positive airway pressure often relieves upper airway obstruction. Obstruction by the collapse of tissue as a result of inflammatory elements, or the collapse of the upper airway due to the constriction of the soft tissue musculature. In the anesthetized patient, an oral airway relieves the posterior displacement of the tongue to relieve obstruction. When do you place an oral airway? You do that when the patient's unconscious. Infections such as bronchiolitis, asthma, and pneumonia significantly affects airway resistance, and the treatment of children with these conditions need to be rescheduled, then risk airway consequences. So bronchiolitis, reschedule the patient. Asthma, unless it's mild, reschedule the patients. And pneumonia is a lower airway obstruction, and it affects airway resistance and treatment. Therefore, try to reschedule those patients. Sedation and respiratory depression. All sedative drugs suppress the central nervous system in a dose-dependent manner. Typically, this is accompanied by a reduction in CO2 responsiveness in the medullary respiratory center. Loss of airway control and respiratory depression are the most common serious adverse effects associated with sedative drug administration. The greater the degree of sedation, the greater the degree of respiratory depression. Respiratory depression increases when combining sedative drugs or when using large doses of a single drug. This is a diagram of a heart with the carotid bodies that you can see, and also the aortic bodies. If you look close to the top of this diagram, you'll see where the carotid sinus baroreceptors are. These are the elements in the medulla which detect the increase in hydrogen ion, a decrease in the pH. When that occurs, the medulla and pontine processes tells the body to increase the rate of respiration. In the bodies that are in the aortic arch, if you look down to the bottom, you'll see the aortic arch baroreceptors. That is the influence of the oxygen and carbon dioxide carrying capacity of the hemoglobin. And when we see those elevations occur, then the baroreceptors will tell the medulla it's time to increase the rate, because we know we don't have adequate oxygen in carbon dioxide on the hemoglobin to affect the respiratory system. Management of pediatric airway. Airway obstruction during moderate or deep sedation occurs in the supraglottic structures due primarily to the soft tissue and epiglottis falling back to the posterior pharynx. While it is previously thought that the base of the tongue was the primary cause of upper airway obstruction during unconsciousness, MRI studies of the airway in sedated children demonstrate that the soft palate and epiglottis are the most likely structures causing the obstruction. The keys to appropriately managing the pediatric airway during sedation are proper airway positioning, the application of positive pressure ventilation when required. Routine management of the pediatric airway includes placement of the patient's neck in the sniffing position, often with a rolled towel beneath the shoulders, and administration of blow-by oxygen very gently occurring. If obstruction persists despite these maneuvers, the patient's airway should be repositioned and a chin lift performed to move the supraglottic soft tissue structures, primarily soft palate and epiglottis, anteriorly and away from the posterior pharynx. If a simple chin lift fails to relieve the obstruction, this should be followed by a jaw thrust and application of positive pressure through a flow inflating anesthesia bag and mask. Failure to relieve the obstruction following application of positive and expiratory pressure requires positive pressure ventilation with cricoid pressure and endotracheal intubation when necessary. Respiratory physiology under sedation. The central respiratory center is primarily located in the medulla and the pons, which rapidly responds to changes in carbon dioxide. Changes in carbon dioxide concentration are among the most important determinants of respiratory drive from the medullary respiratory center. Carbon dioxide freely diffuses across the blood-brain barrier, resulting in an increase in hydrogen ion and a decrease in pH in the cerebrospinal fluid. The decrease in pH is accompanied by an increase in neural output from the respiratory center and in minute ventilation. Minute ventilation typically increases linearly with a rise in PCO2. This is a graph of ventilation control, and on the left you see minute ventilation, and on the bottom you see the increasing line, horizontal line of the PCO2. We can see that when PCO2 moves to the right, there is a decrease in the ventilation, and when that decrease in ventilation occurs, the pH descends. On the left side, the normal, one marked NL, it allows the ventilation control to occur within the pons and the medulla to increase or decrease the level of respiratory rate to affect the position of the airway supply in the respiratory tree. The normal response to increases in carbon dioxide is noted by the line designated NL in the CO2 ventilation response curve. In general, sedative drugs suppress the central respiratory center and reduce the ventilatory response to a given level of carbon dioxide. Doses of sedative drugs that do not cause completely loss of consciousness, for example low-dose morphine or midazolam, usually displace only the CO2 ventilation response curve to the right while maintaining the slope of the response at line A. Under deeper levels of sedation, however, the slope of the CO2 ventilation response curve decreases as well as shifts to the right, line B. This response may occur when combining sedative drugs or using any sedative that results in unconsciousness. A decreased slope indicates less of an increase in ventilation for any given rise in carbon dioxide, a situation that may lead to severe hypercapnia, hypoxemia, or apnea. Airway management. Airway management generally means providing rescue oxygen applied to the nose and mouth and performing with a good seal compressions of the rescue bag, displacing oxygen through the nose and pharynx to the airway. In cases where air management is not successful using the bag valve mask method, then the utilization of airway management graduates to the introduction of an endotracheal tube. These two laryngoscopes, the left one is a Macintosh and the right one is a Miller, shows us how, when, and what to be able to do to displace the tongue, visualize the glottis, and insert the endotracheal tube. The endotracheal tube, of course, is sized. One of the ways to do that is to use the Blaslow tape, which shows us for the infant or child that we have in front of us the approximate average size of using an endotracheal tube. Another way that's commonly used in the operating room is that the little finger of the patient is looked at and the diameter of the endotracheal tube is tried to match up with that size of that little finger. In cases where inflammatory or traumatic events have occurred to the airway, you may see a reduction in the size of the diameter of the airway due to the swelling that goes on due to any infection which might have affected the diameter of the tube, in which case this occurs, select a tube which is smaller in size. Once the epiglottis has been displaced using the Miller or the Macintosh blade, then the glottis is visualized. It appears to be a very floppy valve. The vocal cords are quite floppy in nature, not very rigidly held, and it's very easy to insert the endotracheal tube down there very carefully, provided it is the right size for insulation in that particular patient. If it's not the right size, remember that you are hyperventilating the patient prior to the introduction of the endotracheal tube to be sure that the provided additional functional oxygen reserve for the patient to sustain the few minutes that it takes to get the endotracheal tube in there. If you withdraw the endotracheal tube that you have, go immediately back to the administration of the bag valve mask oxygen introduction and continue to be able to oxygenate the patient while you have the endoscope and the endotracheal tube outside. Select the next size that's appropriate, either smaller or larger, to help obtune the trachea, and then re-inflate the lungs multiple times with your ambu bag and oxygenate in the hyperinflation technique, and then resume displacing the tongue with your laryngoscope, visualizing the glottis, and then inserting the new tube in that location. Sometimes, in cases we have seen in the operating room, this may occur several times if there's difficulty in intubating the patient, and also visualizing the glottis so that the glottis is exposed to a position where we can insert easily the endotracheal tube. Oral tracheal intubation. Patients that become unconscious during deep sedation may not be able to maintain their own airway, and under such conditions, oral tracheal intubation may become necessary. The Miller and Macintosh laryngoscopes can be used to visualize the glottis for intubation. This is a nasoendotracheal intubation. You can intubate the patient either orally or through the nose. For beginners, ventilating or inserting an endotracheal tube through the mouth is the easiest of the two venues because we don't have the turbinates interfering with the insertion of the nasoendotracheal tube. The endotracheal tubes through the nose are much narrower and are able to be inserted. However, one has to recognize through the mouth with the tongue deviated to the side where the tip of that endotracheal tube is in the bottom one, which is one that does not go through the nares but goes through the mouth. It's important to visualize the glottis. So with your McGill forceps, which is the forceps that takes a hold of the end of the tube to place it directly into the tracheal area, past the glottis into the trachea. As you use those McGill forceps to put it down in there, it's important to be able to get it down there smoothly without causing trauma to the glottis. Endotracheal intubation occurs with the insertion of the laryngoscope initially inserted into the right corner of the mouth, displacing the tongue to the left very gently. The scope is moved anteriorly and inferiorly to visualize the glottis in children. Remember that this is at C4 and 5 rather than at C6 with adults. And engaging the vallecula, which is attached with ligaments, to visualize the glottis in children. Engaging the vallecula and lifting it or compressing it against the trachea. Then the intubation is completed by passing it through the vocal cords using the McGill to hold the end of the tube, noting the depth measure on the tube when you're satisfied that this has entered the trachea, and finally tying it by a circular taping of the tube at the point at which you remembered the depth measure, and attaching it to the opening of the nares, around the opening of the nares, and the bridge of the nose. The inflation cuff should be inflated if used with about 5 milliliters of air. And this is done with a 5 milliliter or 10 milliliter syringe on the tubing that comes up from the endotracheal tube, and draw up 5 cc's of air and just attach it to the tube that's connected to the bulb at the end of the endotracheal tube, and just slowly inject until you feel pushback, at which time that's sufficient air to be able to do that. And then remembering in reverse when you're ready to extubate the patient that that air has to be drawn out of the tube to retrieve the tube appropriately. Insertion of the endotracheal tube. This is a new type of device that has colored rings on the endotracheal tube that are demarcated according to the diagram or the graph below, and it indicates the length of, in centimeters, of the distance from the corner of the mouth to where the trachea lies. Once the endotracheal tube is placed in the trachea, it's important to recognize what size that is or what position that is, and with this particular technique you know exactly how far down you are, and if the taping should become loose from the nose or the upper lip or the bridge of the nose, then you can easily replace it with something that, if you are doing the recording of the sedation endotracheal tube placement in your anesthesia document, then you would simply put down it was inserted to the level of 9.5 or 8.5, whatever it might be, and then if for some reason the patient moved, or for some reason during the dental procedure the endotracheal tube was moved, you could refer back to the number on your sedation and anesthesia list and see that at what level you placed it, and you can either put in a new one or using your laryngoscope get in there and replace it at the level that it was. But it's easy to replace, and in the meantime you can put your oxygen source on the end of the endotracheal tube and breathe for the patient as long as it's not in the stomach. Cuffed tubes. It is believed that cuffed tubes can provide better ventilating conditions while also minimizing trauma to the delicate airway of pediatric patients. Therefore, cuffed tubes can be used. It was thought at one time that uncuffed tubes would be the preference. And these days what we see is cuffed tubes are in there, remembering to put that 5 cc's of air when the tube is in its final position, and then tape your tube upper lip or around the nose area. And if you have that latest version, you can simply look at the number and record that, and that's where it's going to be. If you're using one that does not have numbers, you can just wrap the tape around the external portion of the tube as it exits the mouth and mark this is where the teeth might be, or this is where the upper lips might be, wherever you selected to use as your landmark, and then tape it in that position. If it becomes dislodged for any reason, you can reinsert down to the level that you've already taped circularly around the tube, and just simply adjust the tape that you use to hold the tube into its position. So the oropharyngeal intubation technique is a technique that utilizes the laryngoscope, as you can see in this diagram on the right. The endotracheal intubation tube is there. It's placed down on the trachea as it goes through the glottis into the trachea, and it gets down to the right position. Again, putting circular tape around the end of the endotracheal tube and pasting it or taping it to the upper lip and nose area with horizontal tapes and often vertical tapes to keep it from moving. As long as the patient doesn't move, we've got a good situation. If you look at the diagram on the left-hand side, you'll see at the end of the endotracheal tube is an inflated cuff. This inflated cuff is usually about 5 cc's of air. It's going down past the tongue. You see the vallecula there and the epiglottis that's been pushed up, and so it allows that trachea area to be covered and avoiding any aspiration coming from the stomach. These are airway rescue devices. What you see here are some oropharyngeal tubes, and what this is in particular is a laryngeal mask airway. This is for the unconscious patient. And as you look at the diagram on the light, although it is very light in its color here, what we see is that the airway has an opening in it where it reaches over the trachea, and the tube then expresses as the bag valve is squeezed up where the patient is, and the flow under pressure goes through that area of the laryngeal mask airway and allows a consistent airflow to be placed in it. They come in different colors apparently, and when it's placed, you hold the curve away from you and you slide it along the palate, and we'll show you here in a moment how it's supposed to be used. The laryngeal mask airway has a 95 to 98% success rate in achieving adequate ventilation in children. Knowing this, having LMAs available in your rescue kit would be the device of choice, I believe. We know that we can do endotracheal intubation with endotracheal devices. However, if you know that there's a great success rate here with a laryngeal mask airway, then that would be the one to use. And in a study by Tate using an LMA in children with upper respiratory infections, wanting to know, comparing to endotracheal intubation, the LMA had fewer complications. So this seems to be a very good reinforcement for the use of the LMA to use in children as a rescue device. This is how the tube looks, a little bit more clear. The connector that you see that attaches to the oxygen source outside the mouth is a 15 millimeter connection. It's good to remember that because it's universal. What you see is the airway tube going down to the little mask that's there. You have the cuff that goes around the trachea opening, and then you see the aperture bars, which lets the oxygen go into the patient's mouth and provide ventilation for the patient. This is the technique for the insertion of the empty air. You see it's grasped by the index finger and thumb, and the opening of the laryngeal mask airway faces the patient's face, and so as you're putting it in, you're sliding it along the hard and then soft palate, and keep sliding it in. Remember, before you get started using this, there is some lubrication jelly that you should put on it, some jelly that is compatible, biocompatible, and you put that on so it allows it to slide in very nicely. And you see in image 3, it's a curved tube that goes down, and once you encounter some resistance to placing the LMA tube, it shows that you are at the level of the opening to the trachea, and then you put that in and mark the spot. Again, tape that LMA tube to it, attach your 5 milliliter bulb, and put the 5 cc's of air into it until you feel resistance, and then attach your 15 millimeter oxygen source to the rest of your equipment. So if you have any questions about these conditions, it's important that you email us at the PACE Center at uth.tmc.edu. We'll be happy to correspond with you and let you know anything that we can clarify for you. We have gone over in this module the opportunities to place an airway into the patient's mouth. We've also talked about some consequences of inflammation and how gases flow through the delivery device and how it can be affected by turbulent flow or linear flow. The differences between the pediatric and the adult airway, noting that the adult airway is straight and cylindrical, and the pediatric one is very short and more cone-shaped at the level of the cricoid cartilage. So once you get through the glottis, the vocal cords, you know that you're going to be coming up against a very tight tracheal position, because until the patient grows some and matures some, the size of the airway is not going to change very much. And remembering also that when the child reaches 8 years of age, you have a more mature ventilation system. The breathing pattern becomes less, goes to a lesser level, because they're developing some functional oxygen reserve and some residual airway volume. And that's the amount of air that generally is when you expire. If you were doing a forced expiration, the air that is left over in your lungs after you've just let a natural breath out, there is air left. Remember, you are filling a dead space. That's the space from the introduction of the tube, from the beginning of the patient, once it leaves the lips and goes down past the tongue and into the trachea through the glottis, that you have a dead space where no air exchange is occurring and where no amount of oxygen is remaining, and therefore it's a large dead space that's characterized. When you look at the capnography, you'll see the plateau of the expired carbon dioxide, and that's the dead space that goes across there before full expiration is reached. Along with your module today, we've attached the references for this entire course, so it allows you at any time, at any module, to perhaps read ahead if you choose to do that, or to use the information that's associated with your module to be able to read along as you're going through that module. So please do that. Learn how to do this process. Remember to hyperventilate your patient prior to doing your airway insertion, and it allows the patient to have sufficient breath remaining while you put the tube in. Thank you, and have a good day. This completes this section of the course. It is time for you to take a short exam in order to complete the requirements for streaming video courses. Due to the nature of our subject content, a passing score of 80% is necessary in order for you to advance to the next section. Upon successful completion of this exam, you will be visually informed that you have met the requirements to proceed. If you fail to answer enough questions correctly, you'll be instructed to take the exam and a new set of questions will be provided. You will have 3 chances to fulfill the requirements. If you are not successful, you will be instructed to review this section again. Good luck on the exam. If you're ready to take the next section, upon completion of this exam, you will be provided a link to continue. If you wish to proceed at a later date, you will need to log in and they would be very unhappy to see that if you call